You sit next to her. On the surface of the virus, we have this protein called the spike protein. And so we were able to develop this in the lab so that we could then go out and screen blood samples from individuals in the population to determine how many individuals in the population have what we call an antibody response to this protein, the spike protein. There are limitations with the COVID-19 PCR test. The limitations being the human resource capacity to do the testing, the availability of reagents. So obviously that limits the amount of people you can test in the population, whereas if you're able to take a large blood sample from individuals, then you can quickly say how many people have seen the virus. The PCR test tells you who has an active viral infection at the time, so who has virus in their system. The antibody test tells you this person may have been infected in the recent past, may be infected, or may have been exposed to the infection. That means they may have been in contact with somebody who was positive for SARS-CoV-2. So then it will tell you that in the population, we do have a larger proportion of individuals who had actually seen the virus early on in the pandemic than we thought with the PCR test. What we've been able to understand from the data we've been receiving for the COVID-19 testing, because we support the 6 coastal counties in Kenya, was that a large proportion of the individuals early on in the pandemic were asymptomatic, which means they have virus but don't show any clinical signs such as coughing or sneezing, or the standard signs that we know of. That means they're roaming around in the population with virus, but not being sick, and they're not aware that they have the virus. So that obviously you're able to some extent, if you measure the blood sample, you can also pick that up, that they may have been, there are two ways. You may have been asymptomatic and have generated antibodies to that. You may have been symptomatic, or you may simply have been exposed to somebody who was asymptomatic or symptomatic and still have generated an immune response to being exposed to the virus.
The antibody test looks at those people who have been infected in the past 2 weeks or more, and it might actually be understating, because not everybody who gets infected develops antibodies. So we can extrapolate to say that the infection rate or the number of people who have been infected in the Kenyan society is actually much higher as at April to June. Subsequent data by KEMRI, which was published in August but yet to be published in peer-reviewed journals, shows that between 34 to 41% of individuals are actually already infected. So perhaps by now, more than 50% of people have been infected.
There are some features that strongly favor or less strongly favor influenza or chronic inflammation. apoptosis architecture?
The infection is actually quite prevalent, not dissimilar to other countries in the world. The dissimilarity, what is different, is we are not seeing as much people getting sick, getting admitted and dying compared to the other countries which had similar prevalence in terms of the infection.